our device, our diaphragm pacing system for ALS, is a humanitarian use device, and as such, it has been demonstrated safe to the satisfaction of the FDA, as well as showing probable benefit. So as part of our labeling, we are not able to say that the effectiveness of this device has been demonstrated, and we'll discuss that a little bit later on. Our intended use for this application is in ALS patients who have intact diaphragm and have objective measures of chronic hypoventilation, both of which we will talk more, Professor Lechen and Ms. Elmo will talk more about. Next. Of course, there are warnings, and I'm not going to read the whole slide here, but the couple of important ones, MRI, in this patient population, the use of MRIs, we have not done the formal testing, so the FDA requires us to include it as a warning at this point. And when we get that testing completed, we will seek to lift that warning. But until then, it is warned against for this patient population. And the other one that is important and specific to our device here is that the risk of aspiration in these patients. When they first start to use the device, it does not sense the breathing effort by the patients, so there may be a risk of aspiration. So we ask with the initial use that they don't eat or drink while they're using the device until they become more used to the device. So with the initial conditioning, not to be eating or drinking. Next. And of course, as a electromedical device, there are a number of precautions. Certainly not to get it wet. The device is splash-proof, but it is not submersible. So the external device must be not submersed. And there's also always the possibility of interference with electrical devices, other electrical devices. So just to be careful with any electrical medical device. So our device, as I just mentioned, consists of an external pulse generator, which you see on the right-hand side of the screen, connected with a patient cable to electrodes, and the picture of the electrode in the middle there that is implanted into the diaphragm. And it is a surgical procedure where these electrodes are placed into the diaphragm. So the only part of the device that's implanted are these electrode leads. They come out through the skin and are connected to the external device. The idea is that we are conditioning the diaphragm of the ALS patient to provide a strengthening of the fatigue-resistant muscle fibers and providing the benefit that Professor Lechen and Mary Jo will talk about as we move forward. I did want to touch on what a humanitarian device exemption is, and it is a full approval by the FDA. It is not an investigational or experimental device. Humanitarian devices are identified as those in patient populations of 4,000 patients per year or less. So we do expect that this is beneficial in patients, not all ALS patients, and that's what the point of this discussion today is that there are patients to be selected that meet the criteria of our humanitarian device. We did a prospective study.
We demonstrated safety of the device, and we have data that shows probable benefit in the aspects of our use of the device.
But these aspects were not our primary endpoint of our clinical trial. So they were secondary endpoints, and they have to do with survival and sleep, as well as other benefits that we saw in a post hoc analysis. So we did not demonstrate through a primary endpoint analysis of a study, but rather through secondary endpoints, which is why we made the conscious decision to go after a humanitarian device rather than delay through more trials that would show primary endpoint effectiveness. We do have more trials undergoing right now, 2 in Europe, and 1 that should start early next year in the U.S. But those will be post-market studies, and we will continue to keep the world appraised of our pathway along those trials. There are a number of devices that are approved for HDEs. Medtronic has devices for deep brain stimulation as well as the total artificial heart. So there are, we're not unique in that aspect. It's just that it's not the normal pathway through the FDA, but it is a full FDA approval for our device. So with that, I'll now turn it over to Professor Lechen.
Thank you. So this is Noah Lexon. I'm a pulmonologist at Johns Hopkins. Most of my the focus of my presentation is going to be on the evaluation of ALS patients and discussing the indications for diaphragm pacing. So this slide shows the indications for use of diaphragm pacing in ALS as stated by the FDA in their approval. And so as they describe it, it's intended for ALS patients who have a diaphragm that can be stimulated and who are experiencing chronic hypoventilation. And they have criteria for hyperventilation, which I'll get to in a second, but they have not progressed to an FVC less than 45% predicted. So they have to have a diaphragm that can be stimulated. So you need to assess phrenic nerve function either by neurophysiologic testing or visualizing diaphragm contraction either by fluoroscopy or ultrasound. And so hypoventilation in this case has been defined as a vital capacity less than 50% predicted, or a MIP less than minus 60 centimeters of water, or an elevated PCO2 greater than or equal to 45, or an O2 saturation less than 88% for 5 minutes during sleep. And so it's important to keep in mind these are similar to the criteria that is typically used by Medicare for approving non-invasive ventilation, and all of these statements are or, so you don't have to meet all of these criteria. If you meet any of these criteria, you meet the indication as outlined by the FDA. Let's go to the next slide. So one issue that I have with these criteria is that hypoventilation isn't really the right term, and what we're really focused on, if you actually look in the bottom bullet here, what we're really interested in is ALS patients who have evidence of early diaphragm weakness. And that's really a different thing than hypoventilation. So hypoventilation, by definition, means that there's inadequate gas exchange, and by definition, you should see an elevated CO2. In general, patients with ALS usually have diaphragm weakness well before they have true hypoventilation. And if we're waiting to see an elevated CO2, you're probably waiting too long, and you're going to miss the window of opportunity when you can do the surgery on these patients safely and when they stand to have the most benefit. Let's jump ahead to the next slide. So in terms of evaluating these patients and deciding when they have early diaphragm weakness can be a challenge. I think anybody who's familiar with clinical care of ALS patients know that doing pulmonary testing and evaluation can be a challenge. And there's a number of reasons. One is if you're just talking about symptoms, symptoms can both under and overestimate problems in ALS. So patients may complain of shortness of breath or other respiratory symptoms, but it may have nothing to do with their diaphragm. It may be that they're having upper airway problems from bulbar involvement, aspirating, or having spasm of their vocal cords, or just having saliva or other secretions in their upper airway that causes discomfort. And so they may complain of trouble breathing, but it may be that their respiratory muscles are fine. Additionally, because of bulbar involvement, often performing the test can be challenging. So if you're having them do pulmonary function tests that involve making a nice seal around a mouthpiece, oftentimes they have air leaks that are going to underestimate their results, or they just may not have the coordination to do the test at all. Also, just the course of disease can be unpredictable. So some patients progress very slowly, some progress much more quickly, and so it can be difficult to estimate when patients are going to develop respiratory problems. And so you have to have a fairly high degree of suspicion and really be looking at this on a regular basis fairly closely. So in general, the recommendation is to test these patients every 3 months is certainly reasonable, and at times it's worth bringing them in even more frequently. Next slide. So in terms of the evaluation of respiratory status, it really takes a fairly thorough, complete assessment, beginning with asking about symptoms and doing a physical exam, then going on to pulmonary function testing, which by the end of my comments, hopefully it'll be clear that testing these patients really needs to be more than just an upright forced vital capacity. You're really going to miss a lot that way, and so doing things like supine spirometry, measuring maximal mouth pressure, so that's the MIP, or otherwise known as the NIF. If you have the ability to do sniff nasal pressures, that can be very useful. And at times, measuring CO2 or doing sleep testing can be helpful. Next slide. So symptoms, there's a lot of information on this slide and the next, but the bottom line is that if patients are complaining of dyspnea, if they say they feel moderately short of breath, chances are they have some impairment in their respiratory function. Let's just jump ahead to the next slide for a second, and we'll come back. So this slide shows what's known as the Borg dyspnea scale. So it's just a patient-reported scale of dyspnea going from 0, which is none at all, to 10 being maximal. And keep in mind, 3 here is patients saying they have moderate shortness of breath. Let's go back to the previous slide. And so this study, published in 2010, just compared their rating on that Borg scale to other measures of pulmonary function. So they measured upright and supine vital capacity, sniff nasal pressure, maximal inspiratory pressure, CO2, and also maximum pressures by magnetic stimulation of their phrenic nerves. And what they found was that dyspnea was significantly related to the sniff nasal pressure, the upright vital capacity, the supine vital capacity, the maximal inspiratory pressure, and CO2. And that if you use a cutoff of 3, so again, if the cutoff where patients say they feel moderately short of breath, it has a pretty good sensitivity and specificity for identifying respiratory muscle weakness. Okay, jump ahead to the next slide again. And this just shows these 2 figures on the left comparing the Borg scale to either sniff nasal pressures or upright vital capacity. And you can see there's a nice relationship between the 2 of them. And when you get beyond a score of 3, really very few patients have what would be considered a normal vital capacity. So if you use 80% as a cutoff for a normal vital capacity, after you get above a score of 3, virtually everybody is below that. So again, if patients tell you they're moderately short of breath, chances are they have respiratory muscle impairment. Next slide. So certainly forced vital capacity is something we know a lot about in ALS. It's done routinely all across the country. And it's a useful test. Certainly it can be great for following people longitudinally. This slide here on the right, the figure on the right shows just some of the heterogeneity between patients, showing that some patients progress very slowly. This one patient that's followed out all the way to the right, so followed out over 5 years, had a very little decrease in the vital capacity over that entire time, whereas some of the patients on the left that had these very steep falls within yet less than a year went from essentially normal lung function to severely reduced vital capacity. The other thing that this study showed was that at the time of presentation, 86% had abnormal vital capacities, but only 19% at that point had symptoms. So again, really need to do pulmonary function testing right from the get-go and follow it serially. But as I'm going to show in a couple other slides, upright vital capacity alone can certainly still miss early respiratory muscle weakness. Next slide. So there are certainly some shortcomings with the forced vital capacity. As I mentioned before, patients who have weakness of the mouth muscles have a difficult time forming a good seal, and so it can be a challenge to get consistent results. The other thing worth thinking about is that if you're just doing upright vital capacity, it's not nearly as sensitive as supine vital capacity. So it's really worth thinking about doing supine vital capacity routinely. Next slide. So this is a study that I published about 10 years ago comparing supine vital capacity to upright vital capacity and a few other measures. And what it shows is that we compared all these tests to sort of the gold standard for diaphragm strength assessment. That's the transdiaphragmatic pressure, where you put in esophageal and gastric balloons and directly measure the pressure that patients can generate across their diaphragm. And what we were able to show was that supine vital capacity has a much tighter correlation with the transdiaphragmatic pressure. Let's go to the next slide. And that supine vital capacity was much more sensitive than upright vital capacity. And so if you look here, a supine vital capacity less than 75%, so still a pretty good supine vital capacity, had a sensitivity and specificity of 100% for detecting diaphragm weakness. And the only other test that was close to that was the maximal inspiratory pressure, or MIP. And so even if you use a pretty high cutoff of MIP of -80, it has a pretty good sensitivity and specificity. So I'll talk a little bit more about MIP in a second, but I think this is an important table that just shows that supine vital capacity and MIP are really probably the best tests if you want to pick up early problems and don't want to miss those. Okay, next slide. So just to emphasize the value of maximal inspiratory pressure, this is another study comparing forced vital capacity and maximal inspiratory pressure. And if you take the patients that were in the diaphragm pacing study and sort of apply what the findings from this study, the MIP criteria of -60 tends to precede the forced vital capacity by about half a year, and about 93% of the patients in the diaphragm pacing study would meet the MIP criteria, compared to only about 20% in the of meeting the FVC criteria. So again, if you want to catch early respiratory muscle weakness, this is really a much better test than vital capacity. Next slide. And it's worth keeping in mind the equipment for doing MIPS is fairly simple and inexpensive. Sometimes, again, just like vital capacity, it can be a little bit of a tough maneuver for people to do who have bulbar weakness, which is where sniff nasal pressures, I think, really come in handy. So both MIPS and vital capacities require either using a mouthpiece or a mask that can sometimes be tough to get a seal with. The sniff nasal pressure is very similar, except that it uses a little catheter with a piece that goes into the nose, and you just have patients occlude their other nostril and sniff in as hard as they can. And what the bar graph on the left shows is in about 100 patients followed over time, it shows how many patients were unable to do vital capacities, MIPS, and sniffs. And only 4 of the patients were unable to ultimately do sniff measurements, whereas 19 couldn't do MIPS and 14 couldn't do FVC. And on the right, it just shows that different categories of SNP are associated with worsening survival. So as your sniff test goes down, survival is shortened, and it just emphasizes this is a useful measure that ultimately predicts what we want it to. Next slide. So sleep-disordered breathing. I personally am not a huge fan of doing sleep studies in ALS patients for a number of reasons. But there are certainly times when patients' pulmonary function tests look pretty good, their symptoms don't quite add up, and I'm not quite sure what's going on, and if you study them at night when they're sleeping, you can sometimes pick up problems you otherwise miss. if you look at patients who desaturate at night, it actually turns out that it correlates pretty well with MIP, certainly better than other tests. These patients generally don't have run-of-the-mill obstructive sleep apnea. They tend to hypoventilate, just not breathe deeply enough. And unfortunately, a lot of patients with ALS don't do real well in a sleep lab that's not set up to accommodate their disabilities. And so a lot of patients and providers want them to be set up with home studies. And unfortunately, home studies, at this point, the technology is really best at identifying obstructive sleep apnea. So home sleep studies are probably not all that useful. Next slide. Arterial CO2. So again, this is one of the criteria to judge hypoventilation and begin diaphragm pacing. But CO2 tends to be quite variable in ALS patients, and in general tends to be normal until fairly late in the disease course. So if you're waiting for a CO2 greater than or equal to 45, you're really going to miss most of the patients who may stand to benefit from diaphragm pacing. Next. So I kind of hinted and mentioned a little bit about oxygen saturation. So while overnight formal sleep studies can be a challenge to set up, it's pretty easy to set up home overnight oximetry. And while prolonged desaturations greater than 5 minutes is fairly uncommon in ALS, you sometimes do pick it up, and it's a fairly easy, unobtrusive measure. So we've been doing more and more overnight oximetry, and certainly at times I'm surprised that patients who I think are not having any respiratory problems do turn out to have desaturations at night. So I wouldn't necessarily wait to see prolonged desaturations, but again, if your suspicion is high and other tests look pretty normal, it's not a bad idea to do overnight oximetry. Next slide. So the focus of my talk so far has been on the evaluation of patients. I did want to just touch very briefly, and Tony, I think at the end, is going to talk a little bit more about effectiveness. As he mentioned, at this point we don't have big randomized trials to show that diaphragm pacing works, but
there is a prospective study of reasonable size showing that diaphragm pacing is certainly safe, and at this point appears to have probable benefit.
So this slide shows a comparison of 43 patients from the diaphragm pacing study matched to a cohort of patients that I had studied previously, where I was comparing non-invasive ventilation use. And what this showed, if you look at the Kaplan-Meier curve on the left here, comparing survival from the time of diagnosis, survival, the blue line is the diaphragm pacing group, the red line is my standard NIV group. And what it shows is that the group that used diaphragm pacing had a 16-month better survival, median survival than the NIV-only group. So
the data has its limitations for sure, but at this point I think it's pretty clear to me that it's a safe procedure that appears to have some benefit.
So again, my recommendation is really to have a high degree of suspicion. This is something that I think ought to be brought up with patients early on, relatively close to the time of diagnosis, when you're telling them about different treatment options. I think this ought to be in the conversation. We really shouldn't we shouldn't necessarily be waiting for symptoms, although if patients have symptoms, chances are they have abnormal pulmonary function. Certainly shouldn't wait for an elevated CO2 or prolonged desaturation. And MIP and supine vital capacity really ought to be part of the routine evaluation. And as soon as you see some evidence that they have abnormalities, I really think you ought to start if the patient is interested in diaphragm pacing and seems appropriate otherwise, I think it's really worth starting the process at that point. And certainly if you're waiting for a vital capacity below 50%, but trying to find that window between 50% and but above 45%, you're really going to miss almost all the patients who ought to be getting diaphragm pacing and doing your patients a disservice.
So with that, I'll hand it off to Mary Jo.
Hi. So when we have patients that come for diaphragm pacing at university hospitals in Cleveland, we're looking specifically for, do they have some diaphragm dysfunction, and do we think their diaphragm is going to be stimulatable? So meaning it's going to respond to electricity. So things that we do is first we do a fluoroscopy of the diaphragm. Some people call it a sniff test, where we literally watch the patients breathe and look at diaphragm movement. If you have a normal diaphragm is going to move 4 to 5 centimeters when you take in a deep inspiration. If you have at least 2 centimeters of movement, 3 centimeters of movement, even though that's low, that's a good indicator that at least there's some diaphragm muscle that is going to respond to stimulation. Whenever we have somebody that has very little diaphragm movement, we will then get a phrenic nerve conduction study. Essentially, that's like an EMG of the diaphragm, but it's not sticking needles into the muscle. We do a Bolton method where we deliver electrical stimuli into the crook of the neck area to try and see if we can make that phrenic nerve respond to electricity. We look at that fluoroscopy and the phrenic nerve study together, and in conjunction, it kind of makes a prediction, because there are situations, clinical situations, where patients who have a lot of upper motor neuron disease may not have the ability to move their own diaphragm muscle, but may have very normal-looking phrenic nerve studies. Sometimes people may have decent diaphragm movement, and that should correlate then to a good phrenic nerve study. Sometimes if you have decent diaphragm movement, but you get a phrenic nerve study and it's negative, it's possible the phrenic nerve studies are technically difficult, that it's a false negative. So doing the phrenic nerve study alone, because there's a high degree of false negatives and false positives, isn't always the best thing. Looking at a fluoroscopy alone isn't always the best thing, especially if there's somewhat compromised movement. And then getting a flat plate chest x-ray. You can see on this film here, the left hemidiaphragm is slightly above the right diaphragm. Diaphragm should be more or less the same level, or the right diaphragm, it's very normal for the right to be about 1 centimeter or 2 above the left diaphragm. So whenever you see a diaphragm on the left that's elevated, that's an indication that that diaphragm has not been working for quite some time. So again, along with doing a full history physical, these are the things that we look for specifically to see whether or not we think the diaphragm is going to respond. Next. When we've determined we're going to take somebody to surgery, then based on their physical exam and that we think the diaphragm is going to respond, the surgery itself is minimally invasive laparoscopic surgery. So there's four very small incisions made into the abdomen. This is a very similar approach that you would have if you were getting your gallbladder taken out. In the clinical trial, the surgery itself presented no complications, no problems post-operatively, no perioperative problems with the patients at our institution. We've had no failure to extubate. That's always been a big concern, is whether or not you would get people with ALS to be extubated after surgery. We didn't have any of those issues. Some of our patients actually went home the same day. Many of them will just spend the night. Sometimes it's just easier if you're a little weaker from surgery and already are compromised with mobility. We do this surgery with general anesthesia. So again, I said it's failure to extubate. They are intubated, but we do not use any muscle paralytics. If you paralyze the muscle, we can't actually stimulate and find out where to put the electrodes. So, and the other thing that we do with this surgery is, on occasion, we will implant the pacing system simultaneously with the feeding tube. Now, getting a feeding tube is not mandatory for diaphragm pacing, but it does save the patient a different surgical procedure that would require some sedation. So it's one of the things that a lot of our patients did. Their mortality was actually very good. We had very few complications with getting the simultaneous. At our hospital, we had no complications getting the simultaneous procedures. I think somewhere else there was one with the feeding tube complication. But the 30-day survival rate for post-feeding tube and pacing was 100%, which is much better than what PEG alone shows. So again, I just want to reiterate, a lot of people think it's dangerous to get sedation in ALS, but we did not find that to be true at all, and I still haven't seen that. Next slide. After surgery, the surgery itself, I'm going to tell you, takes about an hour. That's going to be surgeon dependent. Some may take a little bit longer. Dr. Anders has done it in less than 40 minutes, but again, the surgery itself takes somewhere about an hour to map the diaphragm and put the electrodes in. Once the electrodes are in, whether that be post-op day 1 or some places may have the patients come back a week later, we will program the devices, and it's literally programmed to pain and sensation. We try to get the highest setting while the patient is still comfortable. So sometimes, especially if you program earlier after surgery, you have some surgery pain, and you can't optimize, so those patients will reprogram a little bit later. But we test each individual electrode. Each of them can be sort of programmed with different power settings. So if one electrode is a little uncomfortable, you may be able to do different settings on the other electrode on the right side or left side. And again, it's the highest settings that we can do to make somebody comfortable at the same time. Next slide. And then pacer usage. In the clinical trial, for people who read it, the goal was to do it 5 times a day for 30 minutes. And it was sort of written into the trial protocol that if patients wanted to, if they felt like it was helping them, that they could use it more. And what I've sort of done and have sort of come up with this little algorithm on how I have patients use the device, sort of based on my experience, is that for someone who has maybe been implanted earlier on in their disease, they're not using any non-invasive ventilation, enough compromise to be implanted, but really not significantly clinically compromised, I will have them do that 5 times a day for 30 minutes. A lot of the patients will adapt that to once or twice a day for an hour at a time. For any of our patients that have any sleep dysfunction, sleep disordered breathing, if they're using non-invasive ventilation at all, I will always have them utilize the pacer while they're using their non-invasive ventilation and or at night when they're sleeping. And this is especially for patients who have trouble with non-invasive. If they have a lot of bulbar symptoms and don't tolerate the mask, I'll have these patients use it at night. Patients that I'll have use full-time, and this is like to initiate, because as disease progresses, we will alter our usage. But patients I have start out using it full-time are maybe those who are implanted a little bit later. For people who have what we call respiratory instability, we started to see this quite a bit when we were watching patients and gathering EMG data, that on occasion, while people may have this hypoventilation at night where they will forget to breathe or respiratory rates drop to 6, you will see that also with some of the ALS patients during their daytime. And for those guys, using the pacer during the day will actually help improve their symptoms and keep CO2s down. So that's sort of the guideline that I use for patients and how we get them. And then again, as the disease progresses or as patients change clinically, we can alter settings, we can increase or decrease if they develop pain later, which is usually not the case, and just increase usage as needed. I think that's, does anyone have any questions? I think that's it.
If you want at this time, you can either raise your hand if you want, or you could submit the questions through the question line or the chat, and I'll respond. The question from Janie is, will you be adjusting the pacemaker only, say, once every 3 months when the patient is seen? Mary Jo?
That would be something that each individual clinic is going to have to sort of develop. We don't have a real big ALS clinic here, so the patients that we implant and we manage, we will adjust, you know, sometimes as often as every 2 or 3 weeks, just a few times. Patients do not necessarily need to have settings adjusted indefinitely. It may just be we were programming them shortly after surgery and the settings were a little low. It would make most sense to reevaluate settings, just like you reevaluate BiPAP settings at every clinic setting visit. It would make the most sense to do that. But sometimes here we'll adjust settings a little bit earlier, and then we sort of reach a point where it's like you're probably fine for the next 6 months or so, and readjust it that way.
Another question came in, what measurements do we have to do prior to referring a patient to a treatment center? So if you're a referral center and you don't have the ability to do the treatment at your local hospital, what typically do you need to have accomplished? Mary Jo, you're very familiar with that. You're basically,
you know, here's the thing. We'll be glad to do everybody's evaluation, but if people are coming to Cleveland, they're already traveling. So if patients will send some medical records to the person or the facility that's going to implant. So if it was me, if I can get a recent H&P, a recent pulmonary study, if they're able to get a fluoroscopy done locally, phrenic nerve studies are sometimes very difficult to get, because not everybody's familiar with doing them, then having those and having us having the ability to look at them in advance will kind of just prepare us for some red flags. So if somebody sends me records and they're using non-invasive 24 hours a day and they have pulmonary testing and their SBC is 30% and they don't have a lot of bulbar, that to me is a big red flag that they are not implantable anymore. And those are the people then I would discourage from coming, or I should say I would let them know that I don't think they're implantable. So it's not like for our treatment center here, we will do all of it, but having somebody, if they're traveling a distance, get some of this stuff done locally kind of just helps give us an idea whether or not, you know, some people then if I tell them in advance that I don't think they're implantable, they're not going to buy plane tickets and spend several $1,000s traveling.
Another question is, how often do you see the patients after diaphragm pacing placement?
Okay, so I'm going to answer this in two ways. I'm going to guess that patients that are going to be done at major ALS clinics will probably have their routine surgical follow-up like 2 weeks after surgery, like most surgeries are done. And then they'll probably be seen as your routine every 3 months in ALS clinic. That's what I would think would be the most reasonable and best way to see patients. We here implant an awful lot of patients that live like literally 5 or 6 states away. I have patients in California, Texas, Florida, Canada, and it's very difficult for them financially and otherwise to come back for routine visits. So I do an awful lot of communicating with our patients on an as-needed basis over, you know, the telephone, via email. Patients have a question about their wire sites or how something looks. They take pictures. They send them via email, and we can manage almost everything over the phone. I have the luxury of having a very small stash of extra pacemakers that if somebody needs adjustments, if it's time, I send them a loaner pacer in FedEx with some different settings. They will then in turn mail me back their regular pacer. We reprogram it as it's supposed to be, and then the patient always then ends up with their own pacer. So that's how I manage reprogramming, and it's done via FedEx or UPS.
Okay. Just because of time, what I'm going to do is progress the presentation. If you have additional questions, please feel free to send me those questions, and then I will address them to the panelists and get a response back to you. I'm going to turn it over to Tony Ignani to talk a little bit about the sleep study that he was involved in.
Well, thank you, Steve. This is another aspect of the trial to demonstrate that that there was an impact or benefit of the device. And again, remember that our device is, as a humanitarian device, is labeled as safe and having probable benefit. So we did another secondary endpoint, which was a sleep study at our group out of Paris with Professor Menegé and Professor Simulowski. And this study was headed up by Dr. Gonzalez, where we had 14 patients involved in doing a sleep assessment at month 3, which was prior to implant. And they then did another sleep assessment 4 months later at month 7. And without the diaphragm pacing device on during either sleep assessment, we just showed the effect of conditioning the diaphragm and showed with statistical significance that there was an improvement in sleep efficiency, which was also translated as an improvement in the amount of time awake after sleep onset, and certainly the arousal index, so the apnea, hypopnea index and arousal index, showed improvements with just the effects of 4 months of conditioning, but without using the diaphragm pacing during the sleep study. So this led us to a publication that just came out last fall, and was another secondary benefit to support the effectiveness of the device, but again, a secondary endpoint that allowed us to proceed with the labeling of safe and having probable benefit. Many of our patients have anecdotally reported that actually sleeping with the device has shown that there's benefit to them also, so that's another aspect that we're going to be looking at in the future. During the clinical trial, Ms. Elmo alluded to the one respiratory failure that was subsequent to PEG dislodgement. A number of patients, actually about a third of the patients during the clinical trial, and this was 86 patients that were evaluated under our humanitarian use designation, about a third of them had PEG feeding tubes placed at the same time as diaphragm pacing, and in one of those patients, the feeding tube became dislodged later in the week, and the patient had to be returned with abdominal sepsis to the hospital and had subsequent respiratory failure and was trached at that time. Later on, the patient did return to pacing and was not full-time ventilator dependent, but never successfully used the diaphragm pacing device for any amount of time. So we deemed that to be a serious adverse event. We had 2 patients that had what we defined as a capnothorax, serious capnothorax. Capnothorax is where the CO2 gas that's used during the surgical procedure for insufflating the abdomen tracks up into the chest cavity. As a matter of fact, in almost all laparoscopic procedures that occurs, but in a normal person having a gallbladder or hernia operation, once that person is extubated, they can take some deep breaths and absorb that CO2 gas rather quickly. In an ALS patient that is respiratory compromised, that's more difficult, so we looked at that closely, and as I mentioned, in 2 patients, chest tubes had to be placed to evacuate the CO2 gas. In 13 patients, we saw evidence of that, and they were able to absorb that CO2 gas without any further intervention, and when I successfully used the device. All of the non-serious adverse events, either moderate to minor adverse events, didn't require any hospitalization or medical treatment. We did have some topical antibiotics that were used for infections at the percutaneous sites, and some antibiotics for infections, the post-surgical infections, but nothing that was deemed serious. The one that stands out there is the discomfort from stimulation, and most of that had to do with the post-operative discomfort and discomfort during that post-operative period. All of those patients we were able to program around, and they were successfully able to use the device to condition their diaphragms. Next slide. We did find out differently from the spinal cord patients, which was our initial experience in these in the use of diaphragm pacing, that we did have a number of more breaks of the wires externally to the body. So none of the leads broke inside the body requiring any kind of surgical intervention, but externally where we had to re-terminate the wires at the connector, just in an office visit or sometimes even at the patient's home, we were able to re-terminate wires. But the ALS patients were much more mobile than the spinal cord patients. We didn't see this problem in spinal cord patients. So we did devise a fix to this and actually tested it in Europe and really significantly reduced the number of events reported. As a matter of fact, I think we've nearly eliminated it, and have introduced that as we've commercially introduced the product. Now we're able to include that in our submission after the trial and eliminate those external breaks. So with that,
so with that, just a couple of questions that are very commonly raised. What's the difference between a referral center and a treatment center? If you go on the company's website, you'll actually see a map. So if you go to synapsebiomedical.com, on the third column is the resources for Lou Gehrig's disease, and in that column on the second row is an interactive map with treatment centers being designated in black and referral centers designated in blue with pop-up tiers. And so what's the difference? The difference has to do with, oops, sorry, my bad. A treatment center has to have IRB approval. Typically, it's coordinated with the local IRB coordinator. If the physician tries to do it, they can get the process bogged down. You need to identify a minimally invasive surgeon. They can be a general thoracic or trauma surgeon. And the hospital that's a treatment center coordinates most all the insurance for commercial insurance and regional Medicare notification. The referral centers are extremely important because, as Mary Jo said, there's all these preoperative testing that needs to be done. A lot of questions from people because they live in areas of the country where there is no support, so consultation support becomes critical. I'm going to go back to the map. As you can see, there's states where patients have to drive to gain access to a consultation and potentially working up their testing. So referral centers are critical for helping these patients. And then post-operatively managing the patient's aspect and working with the treatment centers to have the settings changed as necessary. So patients may, in general, use more and more time on the pacer, but if the stimulation settings need to be changed, then what will happen is they'll increase the settings. Another common question is about reimbursement. We have an extensive reimbursement package which is available on our website to both treatment and referral centers. I'll point that out to you just real quickly. Again, if you go on our website, you go all the way over to For the Hospital. It's going to ask you for some login information. If you contact me, I usually give this to all the centers at the time we begin a dialogue. It will give them access to the IRB package for filing. It will give them access to the reimbursement information. On the clinical side, it has a number of clinical resources, including the video of the procedure for the clinical team to get comfortable with that. Since FDA approval, we are working with the commercial insurers now. Anthem, Blue Cross Blue Shield, has recently adjusted their national coverage policy. So this bullet here should actually be both Aetna and Anthem. We anticipate, like with spinal cord injury, that commercial insurers will update their policy. What usually happens is the administrative reviews confuse HDE with IDE, and you get an administrative rejection. And so the PALs need to be aggressive in monitoring their appeal process. We provide all the centers appeal templates, appeal resources. We work actively with the ALSA if necessary, but they need to monitor their appeal process. Medicare, as you probably know, it's a one-time application per region to just get notification. The process usually doesn't kick off until a PALS presents to the hospital, and then the hospital seems to marshal up against the process itself. Treatment centers will have to send a letter to one of 15 regional Medicare intermediaries. Review takes about 45 days. So if that is done at the time of IRB, instead of waiting for a first patient in parallel, it'll prevent the patient from having to wait. And especially, as Dr. Letchen said, if the patient is low on their FVC, they may slip too low to be treatable. Medicare will insist that the patients be inside the indications for use, or the hospital will have problems obtaining reimbursement. Synapse does partner with each institution. Referral centers receive hard copies of the Q&A brochure. They receive a hard copy of the sleep study. They receive a patient demo kit to show the patients exactly what the patient kit looks like, what the electrode looks like, what the gray cable looks like. They receive patient education information for either communicating through newsletters, or if the hospital is first to treat in a state or in a regional area, they'll usually try and do our outreach via television media. We've had very successful educational efforts working jointly with hospitals. We have set up national distribution support for the consumables, the batteries, the gray cables. There's two support systems on our website. If you go to supply and ordering, they're listed on supply and ordering for your team. And in closing, it's just important to recognize that although we are a HDE device with safety and probable benefit, the FDA did review our data and did provide us 4 statistically significant claims as to the benefits for the technology. So there's usually a lot of controversy about, yes, probable benefit, but we had statistical significance in 4 aspects: improvements in survival at diagnosis and at time of NIV, improvements versus PEG treatment, improvements in patients that were not able to use NIV, and statistically significant improvements in sleep. So I had to rush through mine. If anybody has any questions, we'll be providing a copy of the slide deck for reference to ALSA. Please be sure to take a moment, if you're supporting at the clinic, to respond to the post-webinar survey. We're trying to understand what we need to do better to support you and your patients at the clinic. I want to thank everybody for their time. I do appreciate you hanging on. We ran a little bit over. Please feel free to submit to me again to my email address. You can contact me on the company website. If you go to staff, that's Mr. Ignani. My name's Stephen Unziato. My link to my email is right here. Any questions, any support that you need, please feel free to reach out to me. Again, everyone, have a great weekend, and thank you for your time.
Thank you, everyone, and I'd like to thank the ALS Association for sponsoring us also.
And thank you to our presenters for carving out time, Dr. Letchin and Mary Jo. We do appreciate it. Take care, everyone. Bye-bye.